Greetings from New York. I'm Dr. Scott Friedman, here to discuss this month's focus feature in the Journal of Hepatology. My article this month focuses on a single article in the same issue addressing the pathogenesis and potential clinical treatment of polycystic kidney and liver disease. In particular, I make a point of reviewing a lot of the new and exciting biology underlying the genetics and pathogenesis of these ciliopathies. Two major proteins, polycystin 1 and polycystin 2, have been implicated in different forms of polycystic liver and kidney disease. And the clinical trial by the group from Drenthe and others in Nijmegen in the Netherlands examines whether the accepted therapy of octreotide alone is as good as octreotide plus everolimus, an mTOR inhibitor. Now let me back up and give you a little bit more detail. The understanding of these polycystic diseases has exploded in recent years with the development of mouse models and a clear understanding that these represent a family of disorders that affect the cilia. Abnormal cilial function leads to cyst formation, but it also can lead to inflammation and fibrosis, a component of these disorders that is quite mysterious and still poorly understood. What is known, however, about these cysts is they are associated with markedly elevated levels of cyclic AMP, and that provoked animal models and then ultimately successful human studies that show that octreotide, which inhibits cyclic AMP formation, is therapeutic in reducing cyst size in patients with polycystic kidney and liver disease. There is also evidence that mTOR activation is a key component, and that led to further animal studies that suggested that mTOR inhibitors might add value as therapies to block cyst enlargement. And so the clinical trial conducted by investigators in the Netherlands in 44 patients examined the efficacy of octreotide alone, the established therapy, versus octreotide plus everolimus. Unfortunately, the trial was negative. The studies showed no advantage to combining the drugs compared to the well-established octreotide alone. I particularly like the fact that the journal chose to publish this article even though it represents a negative study, and hope that this encourages editors across the discipline to publish more negative studies so that we understand what works and what doesn't, because even negative studies can have important implications for defining new pathogenetic pathways. The other important thing is that this study emphasized the importance of new potential trial designs, not because this trial design itself was unusual, it was actually quite conventional, but rather because with diseases that affect a relatively small number of patients, we need to be increasingly creative in how we develop clinical trial designs so that we can change therapies in midstream, refine subgroups, and adapt as the trial is ongoing. And so I encourage the readers to learn more about adaptive clinical trial designs as another way to accelerate drug development and also to establish when drugs are not effective. So in summary, this paper by the group from Nijmegen, Drenthe and colleagues, both represent an important translational effort to build on the pathogenesis of polycystic liver disease by testing an mTOR inhibitor, but it also illustrates some of the broader issues that we still need to grapple with in developing clinical trials and advancing our knowledge in diseases that are relatively uncommon but which have a clear genetic basis.